Welcome to another episode with Dr. Muhammad Al-Mu'taz. In this episode, I will be covering how to read chest x-ray for medical residents and interns, and if you're an attachment student. This is something that I've been noticing for the past year or two. That is that most students, when they come to the hospital, they usually don't have a clear idea as to how to read the chest x-ray. However, they are able to identify pathology when they see it. That is something good because they at least have an idea of what a chest x-ray normally looks like. So without further ado, I'll have a chest x-ray up here and I'll be explaining what exactly happens and what it is that we're usually looking at and how to read a chest x-ray in the right proper way. Number one is the identification of the patient, and then I'll identify two methods that are usually used and I personally use, and they help me clear out anything I want to see and to make sure that I don't miss any pathology that can be seen. Without further ado, let us start. So for the first part, we mentioned the identification. The identification is the most important part. You cannot be diagnosing patients with different diagnoses if by mistake you have a different patient's x-ray there. So make sure you read the name of the patient and two or three names. Sometimes patients might have identification and the same identity's name as another patient. The second thing is that you have to make sure that the ID number is the same, depending on your hospital's protocol and your country's protocol. And the third thing is that you have to look at the orientation of the chest x-ray you're reading. Either it is the right or left, and if it's AP, anterior posterior, or posterior anterior. These are different to read, so make sure you pay attention to those. And then you move on to the chest x-ray itself. So there are two ways we usually read the chest x-rays. Number one is through the ABCDE. The second way is from the inside to the outside or outside to the inside. So let us come and look at this chest x-ray here. You can see that there are certain identifications here. However, the most important thing I would say is that you have to have the proper approach. And the thing I mentioned, ABCDE, is the way I usually approach chest x-rays. So for the A, I use it as the airway and the air. So for the airway, you can see here, this is the trachea, this is the carina, then you have the right main bronchus and the left main bronchus. This is the airway. Then you have the air. We're still at the A. These are the two lungs. Okay, you can see them. Normally they are black in color, not fully black and dark black. You can see shades of gray within it. This is a normal lung. Then you move on to the B, which is the bones. You can have a look at the ribs. You'd usually see around 9 to 10 ribs in a normal x-ray. Then you can compare it to the other side and you can see the spine. Okay, if a patient has scoliosis, then you would see a different pattern. Some people, fellow residents, they usually have the B as breathing and they involve the lungs in those. Then you have the C, which is the cardiac silhouette. You can see here the cardiac silhouette. This is the heart. You have here, this is the aortic knob. Then you have the pulmonary trunk around here. Okay, the left atrium is generally towards the posterior side of the heart. And then you have the para-aortic line. You can see it here. It is in close proximity with the spine itself. This is the left ventricle. And you have here the right atrium. And this whole thing is the right ventricle. And you have the interlobular artery around here. Okay, you can see this is the costophrenic angle. And this is the cardiophrenic angle. And then you move on to the D, which is the diaphragm. Normally the diaphragm will be in a semicircular curvature. However, in certain diseases, you would see it flattened. And if it's straight and flattened, you'd suspect diseases such as COPD and asthma. However, in this instance, you can see that it's normally elevated in the right side and slightly lower in the left side. And you can guess that is because of the huge organ we have here, which is the liver. And finally, we move on to the E, which are the extras. Anything extra. You would notice certain things that are anomalies to the whole situation. For instance, an NGT might be placed and you'd see that going through the esophagus down to the stomach. And by the way, chest x-rays are really good at detecting perforated viscous. You have the patient stand for almost 10 to 15 minutes and then you keep them under an x-ray and you'd notice that they have air under the diaphragm. So this is for the ABCDE approach. However, there is another approach that is very simple. However, I usually sometimes miss things with this approach. It is from middle to the outside. So you come here towards the spine and then you move rightwards down up to here and then to the left side and here. You start to see anything that is abnormal to the situation. So you have to examine it from up to down and then from middle to the outside. I hope that is clear as to how to approach a chest x-ray.